In this lecture, we're going to wrap up our chapter on blood with some clinical applications. So the first clinical application I know you've all heard of is anemia. So what is anemia? Anemia is kind of a generic term for any time the blood has a decreased ability to transport oxygen to the tissues. These are some common signs and symptoms of anemia. Now remember, a sign is something that someone else can see or measure, where a symptom is what the patient experiences. And you certainly don't have to memorize everything here, but I'm sure you're familiar with some of these signs and symptoms of anemia. So basically, the person's going to be tired because they're not getting oxygen to their brain as well. Oxygen transport is inhibited. So there's many different causes of anemia. So one cause could be insufficient number of red blood cells. So you already learned about the hematocrit. And the hematocrit is a really good test. It gives us our percent of red blood cells. And as you learn, there's many different reasons why a hematocrit might drop. So one reason why the hematocrit might drop is you're hemorrhaging. Now, obviously, if you cut your foot off, it's pretty obvious that your hematocrit will be low because you're hemorrhaging, right? External bleeding. But you can also have internal bleeding that isn't as obvious. You could have blood in the stool. You could have bleeding from the GI tract, which would be detected that way. You could have maybe post-op surgery. There could be internal sutures or internal bleeding or trauma, right? If there's a blunt force trauma or sporting injuries in the abdomen can cause internal bleeds that aren't as obvious. So hemorrhagic anemia, low hematocrit due to a bleed. Hemolytic anemia, again, you have that lyse there, that lytic word. This is when your red cells are lysed prematurely. Now, normally about 10% die just because, remember, they only live 3 to 4 months anyway, and that's normal. But if more than that are dying, it's usually because they're being attacked by something. So they could be attacked by bacteria or bacterial toxins. Your own immune system might attack them, or different drugs and medications can do this. Well, when they're lysed, that hemoglobin is broken off, and then you have to get rid of that, and all blood gets filtered by your kidneys. And so this is the one where you might measure the urine, and you would see hemoglobin urea. So there would be hemoglobin in the urine because it's being broken up in the bloodstream before the spleen can get rid of it. Now, aplastic anemia is a low hematocrit, but it's not due to bleeding or anything attacking the cells. They're not being made. So in aplastic anemia, there's a problem in the bone marrow. Remember, the red bone marrow makes all blood cells, by the way. So if we're just looking at the red cells, however, with anemia, these are things that destroy the bone marrow. Now, there could be a hereditary condition. Some medications do this. Anti-cancer radiation definitely attacks the bone marrow and can cause this. And other antibiotics and even anti-seizure meds can cause this as well. And then pernicious anemia is a lack of vitamin B12. Now, vitamin B12 is a pretty big vitamin, and so it needs to bind to what's called intrinsic factor. I think we mentioned this already, but I'll just write it again. Intrinsic factor is made by the stomach, and you need it to get B12 in. This is why B12 is often given as an injection. So someone with pernicious anemia does not have enough B12. In fact, when you have those gastric bypass surgeries, you have to watch this and make sure that the patient doesn't end up with this. Now, again, it could be because of the blood cells. It could also be anemia, could be a problem with the hemoglobin. So maybe the issue isn't that you don't have enough red cells. Maybe the issue is something with hemoglobin, and one is called iron deficiency anemia. So notice your normal blood, that hemoglobin binds, and you get this with the oxygen, you get this nice reddish, I don't know if redder is a word, reddish color. When you're looking at iron deficiency, the blood's more pale. You don't have as much of the iron, and so it's not binding as much oxygen, which can affect the color of the blood. So this is more common in women, especially obviously women who are menstruating, because every month when you bleed, you lose that blood, and the iron's in the blood. And so you don't get to replace that. So you want to make sure that you're getting enough iron in your diet to help with this. Another thing that could happen with abnormal hemoglobin is sickle cell anemia. Now, you can have sickle cell trait and sickle cell anemia. You would have learned about these in Bio 119. But what happens here, you can see that it's actually one DNA base mutation that causes a different amino acid, and it changes the shape of the hemoglobin. So when the hemoglobin changes shape, it changes the whole shape of the red blood cell, and they have this sickle shape to them. Now, the problem is, your normal cells kind of like a soft contact lens. It can go right through the capillary. The sickle shape can't. It can get stuck inside the capillaries, and it can cause damage to the capillaries. It can block blood flow. When a patient goes into a sickle cell crisis, it's very, very painful. It can cause blindness. It can damage the kidneys, and the treatment is a blood transfusion. And what happens is hypoxia makes it even worse. So if you have sickle cell trait, you might not ever go into a sickle cell crisis. But if you were maybe to go up in altitude or get a severe case of pneumonia, that hypoxia can aggravate the condition. The opposite is polycythemia. This is too many red blood cells, and so this is something you would see with blood doping. Also, dehydration can make your blood a little thicker, and what we worry about here is that blood starts to get thicker, and if the blood's too thick, it affects how it flows through the capillaries and can cause problems. Now, leukemia was mentioned briefly. Leukemia is bone marrow cancer. So you've heard of leukemia and lymphoma. So the bone marrow is where the cells are made. We mentioned all cells are made in the red bone marrow. But what happens is you have too many white cells. And so what happens is the white cells start to accumulate in the marrow, and they crowd out the red blood cells and platelets. So often those cells decrease in number. So the hematocrit drops. You got to watch for clotting issues because your platelet count drops. And then these abnormal white blood cells go into your bloodstream, and they like to go hang out in your lymph nodes, and that's how you get lymphoma. So we're not going to go a lot of detail on leukemia, but when you look at the leukemias, and you might know someone who's had leukemia, there's different types of leukemia. So it's usually named whether it's acute or chronic. So you see chronic and acute. And it's also named according to which stem cell. We talked about those white blood cells in the bone marrow and the stem cells. Which of those are affected? Because remember that cancer is when you have a mutated cell, it just makes more and more copies, right? It just runs amok. Mitosis it runs out of control. Now, acute often happen in children, and chronic tend to happen in older individuals. The acute tend to be more aggressive, meaning they replicate faster. However, a lot of the drugs target any cell that undergoes rapid mitosis, so they often respond a little better to the chemotherapy. Chronic tend to be more slower. In fact, you might have, like a grandparent has a chronic leukemia, and they might pass away from a heart attack and not from the leukemia or lymphoma. But if you're looking at signs and symptoms, again, because those white cells proliferate and tend to lower your red cells, you could be tired a lot. Your spleen can enlarge, especially the spleen, because of lymphoma. That's where the white cells go and hang out. And so these are some signs and symptoms of leukemia. Lots of different treatment options. We're not going to go through all of them. Again, if it's a chronic, it might just be a watchful waiting because it might be so slow growing. Typically, the treatment is the chemotherapy, right? And the chemotherapy you learned about in Bio 119. These are drugs that target cells that undergo rapid mitosis. So they're going to try to wipe out and interfere with mitosis, but they affect any cell in your body that has a fast mitotic rate, like skin, hair, the lining of your stomach. Now, there are these targeted and biological therapies, kind of keep those together. And these are things where they actually use your own cells to fight your cells. So they can actually take T cells out of the body, expose them to the cancer antigen, train them, so to speak, and then put them back in the body, or actually replicate them, make a lot of them, so basically clone this army, and then put it back in the patient, so now they have a specialized army against their particular cancer. We also know that for leukemia and lymphoma, stem cells is the gold standard. So if you can wipe out the bone marrow and you can find a donor who has bone marrow that will work in your body, that your immune system won't reject, then you're cured because they just destroy all your bone marrow. And at that point, obviously you don't have an immune system. You don't have white cells. So it's very important that you're in a sterile environment. When you get the new marrow, that proliferates, it replicates, and now you're cured because those cancer cells have been removed. This is just an overview, a little bit about immunotherapy. I put a link in here, and if you want more information, it's changing constantly. So I would just Google immunotherapy and look up like the National Cancer Institute for information. Especially if you or a loved one has cancer, it would be really good to see what clinical trials are doing with the immunotherapies now. You've probably heard of mono, right? We call it the kissing disease because it's spread through body fluids. It's actually a virus, the Epstein-Barr virus. It usually runs its course just like the flu, and you can see your classic signs and symptoms of mono, feeling really tired, having a sore throat. They do think it might be responsible for chronic fatigue syndrome, which is kind of like having mono all the time, which I think would be really horrible, because they think that in some individuals, this virus kind of hangs out and your body doesn't clear it. Now, thromboembolic conditions. So a thrombus is an abnormal blood clot. Remember, you only want to form this platelet plug when you've had an injury. You don't want to make one just hanging out. So a thrombus is an abnormal blood clot that's formed. It's a stationary blood clot. Things that make this happen when it shouldn't. Well, it could be genetics. We talked about those procoagulants. Maybe you have too many procoagulants, or they're too active, so they're always trying to form clots. Or you don't have enough of the anticoagulants. And we mentioned this protein C deficiency. Remember, protein C is an anticoagulant. And so there's individuals who don't have enough of this. So if you don't have the brakes, so to speak, you're more prone to forming clots. So it could be you have overactive procoagulants, or you don't have the anti. We also know immobilization and slow flowing blood increases your risk of clots. So being on bed rest is not good because it can increase your risk of clots. Anytime blood isn't really circulating, it's more likely to clot. So if you're on a long airplane flight, get up and walk around, get your blood moving so you're not just sitting there and stagnant. In fact, your platelets are stickiest first thing in the morning. In fact, most heart attacks tend to happen first thing Monday morning. So that's why some people might get up and exercise a little bit in the morning, because exercise keeps your platelets prevents them from getting sticky, so it's helpful. Now, if this clot breaks off and travels, that's called an embolism. And the issue is that eventually it's going to plug up a smaller vessel. And when it plugs up a smaller vessel, blood won't get to that area. So we'll talk about this later when we do respiratory, but you might have heard of a pulmonary embolism, where a blood clot blocks one of your pulmonary vessels. And by the way, these thrombi, thrombus and embolism, are the number one causes of, if I say MI, myocardial infarctions, and they can also cause strokes when you have these abnormal clots. So the treatment is going to be on an anticoagulant. So if you're prone to clotting, you might take one daily. Or you can also take them if you are having issues where, they can give these to a patient who's having a heart attack. Now, we're not memorizing all of the details. I only put this slide here because I kind of liked how it broke down the mechanism. So I like you to really understand mechanisms, like how do drugs work. So when we talk about a blood thinner is a generic word. Basically means it thins your blood and prevents clotting. Some of them are actually anticoagulants, so they interfere with the procoagulants. So they might interfere with factor 10 or vitamin K or thrombin. So these anticoagulants are going to decrease that coagulation pathway. Some drugs are antiplatelets, so they might prevent the platelets from getting sticky. And then thromboembolics are called clot busters because these are going to break up the clot. So in your notes, you have heparin and Coumadin and aspirin, and then you have all the new anticoagulants listed. And again, it's not as crucial that you memorize the name. I just want you to understand the basics. So your anticoagulants, heparin. Notice heparin's going to try to interfere with thrombin, so it's going to be really good. Coumadin or warfarin is going to interfere with vitamin K. Remember that vitamin K is necessary to make all those procoagulants, so if you block it, the liver can't make them. So fewer procoagulants, fewer clots. The good thing about Coumadin is that you can be given vitamin K if they accidentally give you too much, because you also don't want to start bleeding, right? Spontaneous bleeding. You'll have like easy bruising. You might see little red dots on your skin if you're bleeding too easily. Now, aspirin is an antiplatelet drug. It actually prevents the platelets from clumping together. So some people take aspirin daily just to help keep their blood thinner or keep their arteries healthier. Or if you think you're having a heart attack, you can take some aspirin. It might help and prevent that clot from forming. And then I put the brand names for Daxa, all the new ones out here, because these are just slightly newer. They work differently. They inhibit fibrin instead of inhibiting thrombin. They're a little faster. Supposedly they're better. I've had nurses and nurse techs tell me they've seen different, issues with all of them. But the problem is that they don't have an antidote. So if you accidentally, if you don't have the dose right for your patient, you have to just be really careful because there's no quick antidote you can give. Once you block factor 10A, you block factor 10A. Now, a thromboembolic, however, is a clot buster. So these are the guys that they're given, like maybe you actively are having a heart attack or a stroke and they know it's due to a thrombus. Then they're going to give you these drugs because, like we showed earlier, they're going to go in and dissolve the clot. So streptokinase actually comes from a bacteria. They also have TPA. I think TPA might cost more. I'm not really sure. But both of these, their job is to go in and break down the clot. Oops, I hit the wrong button. Here we go. Now, hemophilia, I mentioned, it's X-linked, so it's usually passed from mothers to son. It can affect any clotting factor. Remember that there were 13 primary ones, so they're mostly proteins. DNA encodes for your protein, so if there's an issue with a gene, you won't make the protein, and it just depends on where it is in the pathway for how severe the hemophilia is. And I put impaired liver because we know that the liver makes all these procoagulants. So if you have liver disease, you're probably going to have a prolonged clotting time, meaning it takes longer for your blood to clot, and you might bruise more easily and have more bleeding under the skin. And I also put this picture in just so you could understand the difference when you have hemophilia, right? It's called the bleeding disease because it takes longer for you to clot and to stop bleeding. So we worry about blood loss with that. And lastly, I just want to wrap up with two quick things. There's always blood shortages. You get 3 extra credit points if you donate blood. You just show me the card, take a picture of the card, because I'll always write when you donate. If you can't donate, go volunteer for an hour or have someone donate for you. But we need blood, right? There's always shortages. So they're working on trying to make it. So one thing, when you get transfused, a lot of times you're not given whole blood in a transfusion. Sometimes you might just be given like packed cells, like red blood cells. Sometimes you might just be given platelet therapy or just plasma if they need to boost your blood volume, They are trying to genetically engineer it. They're trying to get stem cells, and when they get the stem cells, they extract them, and then they're trying to replicate them and multiply them so they can make more blood, because the idea is you really need the red blood cell. You can do a plasma transport, right, if you just need to maintain blood volume, but it's those red blood cells that transport the oxygen. So they're really trying to figure out a way to recreate those red cells so that the patient doesn't become hypoxic. And then the platelet-rich plasma therapy, we talked about briefly if you had me for AMP1. You basically take your blood and you want to get after those platelets. Remember, the platelets are in that buffy coat because platelets have all kinds of growth factors. So what's a growth factor? A growth factor triggers mitosis. So growth factors are critical for wound healing and tissue repair. And what they found is that if you take these platelets and you inject them in the injury, it significantly decreases the healing time. It stimulates how fast those tissues can regenerate. So they use them a lot when they have damage to ligaments and tendons because it helps especially the athlete get back to the field sooner. And now it's available for us lay people. So this concludes your clinical lecture on blood.